Hi, everyone. On behalf of GU Oncology Now, I'm Brian Rini. I'm the Chief of Clinical Trials at Vanderbilt University. I'm pleased to be joined today by an expert panel of kidney cancer experts, and we're going to talk about really the spectrum of therapy for frontline kidney cancer, from observation and drugs, and also some of the new data, including triplets and what will be coming out in the next year. So I'm going to have each panel member introduce themselves, and we'll start with you, Dr. Ornstein.
Hi, I'm Dr. Moshe Ornstein. I'm a GU medical oncologist at the Cleveland Clinic, where I spearhead the RCC efforts.
Hi, I'm Shuchi Gulati. I'm an assistant professor at UC Davis Comprehensive Cancer Center. I'm really excited to be here.
Monty Pal. I run the kidney cancer program at City of Hope in Los Angeles.
Great, thanks all for being here. So let's close with new data you're looking forward to this in the next year, let's say, or drugs. We didn't touch on belzutifan, a HIF inhibitor. What's exciting? What do you think's gonna come out and impact practice? We talked about 8x8, so we'll take that off the table, but what other data is coming and what might be most impactful?
I don't know how soon it's coming, but this phase 3 of everolimus versus belzutifan in heavily refractory patients probably is going to be the first, I would imagine, of these phase 3 studies to hit. I can't imagine that belzutifan wouldn't win out against everolimus, with the response rate of 2% and a PFS of 1.6 months, in its own phase 3. If belzutifan doesn't meet that mark,
we got a problem.
We've got a problem.
Cancel the Merck trial.
Right, exactly. So once that agent comes into practice, I think the big dilemma is going to be: do we go TKI-IO to TKI and then to an agent like tivozanib, or will we go down the path of belzutifan? I mean, it's going to be a really interesting dilemma.
Yeah.
And I'm not quite sure what I'll do at this point.
Yeah, no, I'm not either. Shuchi, what are you looking forward to?
Yeah, definitely the belzutifan and also the CONTACT-3 data to guide us on the sequencing question.
And CONTACT-03 is Cabo-Atezo versus Cabo in a IO refractory population.
Exactly.
TiNivo-2, which is still accruing, is tivozanib nivolumab versus tivozanib in that pretty much same, including post-adjuvant, right? So
Yes.
adjuvant pembro failures were allowed in CONTACT as well?
Mhm.
Yeah.
Yes.
So that we're not going to cover that, but that's a whole segment of patients we have no idea what to do with. But
Exactly.
kind of asking, do patients get a second shot at immune therapy?
Exactly.
And do you think, maybe for the group, for those studies, do you think there has to be an OS benefit for them to get used? I think they're probably PFS, OS co-primaries, but
Yeah.
do you think?
I mean, it's going to be so hard to demonstrate an OS advantage, and that hasn't really been our bar in the refractory setting to date.
But maybe it should be.
But maybe it should. Okay, all right.
No, but I think
controversial in the last
right.
couple minutes here.
No, up until now, the bar for frontline has been OS, and the bar in the refractory setting has really been the PFS benefit.
Yeah. But I guess I would counter, and I'm not sure I have a strong opinion on this. That's because we haven't had curative drugs in the refractory setting. We would hope that immune therapy can be curative in the refractory setting. So, I agree. If there's a statistically significant PFS, they'll get approved and used. But I'm just sort of pushing it to say, like, should we be demanding, in other diseases, we say, well, you can't show OS when we haven't shown it, and then a potent drug comes along and suddenly you show it. You know what I mean? That's happened in other diseases. So I guess the question is, do you think there'll be an OS advantage?
I don't think so. I'm not convinced there's going to be a PFS advantage.
Yeah.
So I think we don't see a ton of PFS benefits from IOs in general. And I think something happens to a patient's RCC biology when there's disease progression on an IO agent. And I'm really not convinced about the activity. And we had TiNivo-2 open and CONTACT-03 open, and we accrued. I think it's an important question to answer. But I'm really curious to see the results.
Yeah, I've just seen so many, patients referred into my practice who have been on 3 or 4 sequential IO-based therapies. I'm just thinking to myself, what an amazing sort of societal economic cost this is coming out with zero data, right?
Well,
yeah.
There's an immunotherapy halo effect, right? Where you might not do that with, I don't know, a MEK inhibitor, something else, some other, there's this halo effect where, because you're always holding out for that durable disease control, right? Because we've all had patients who were rescued, right? We all have those dramatic patients who were rescued. And so, it's a bit in desperation. I'm not justifying it, but I think I understand the philosophy.
And I was doing this talk last night with Dave and McDermott, and Chuck Drake was actually in the audience, which was amazing. It was a great opportunity to add. I don't know why he came to my talk. Poor choice. But I just thought to myself, I asked him, what do you think about this principle of IO followed by IO? And he said, well, to many folks out there treating breast cancer and other diseases, the paradigm exists, for instance. With HER2-directed therapies, for instance, you use that through the continuum of treatments for breast cancer. ER/PR-positive disease is the same. So there is that paradigm in oncology, but we probably do need to try to, deflate it if it's not helping patients.
Yeah. There's the paradigm, but diseases are different. Like you said, myeloma is different, et cetera. So we certainly need level 1 evidence. So. Well, with that, I think we'll close. I'd like to thank Drs. Pal, Gulati, and Ornstein for joining me in this GU Oncology Now discussion. It was a great discussion of frontline therapy. Thanks, everyone.
Thank you.
Thanks.
Fun.
Thanks.